Okay, so our first case is a locally advanced GE junction cancer. A 55-year-old man with long-standing reflux presents with solid food dysphagia. Endoscopy reveals a 3-centimeter mass in the GE junction, 40 centimeters from the incisors, and a biopsy reveals adenocarcinoma Siewert 2. A CAT scan of the chest and abdomen reveals a GE junction mass and no metastasis. Endoscopic ultrasound reveals a T3N1 lesion, and a fine needle aspirate of one of the periesophageal nodes is positive. A PET scan reveals a PET avid primary mass and no evidence of metastatic disease. HER2 testing is negative. So please vote. Your choice of therapy is preoperative ECX for 4 cycles and then surgery, preoperative CF for 2 cycles and then surgery, preoperative paclitaxel, carboplatin radiation and then surgery, surgery first and then postoperative 5-FU and radiation, induction chemotherapy with Folfox followed by 5-FU oxaliplatin radiation and surgery, induction chemotherapy with Folfox, repeat a PET scan, and change the chemotherapy during radiation if there's no PET response. Okay, so the first 3 choices would have been the standard options. So 42% picked paclitaxel carboplatin radiation. I think David's presentation might have swayed people a little bit away from option 1, but there are still some believers, 8%. 25% actually would operate first and give postoperative treatment, and then a smaller number would use a 5-FU oxaliplatin with induction treatment, and then no one picked using a PET scan to guide therapy. So comments from our panelists? Yes.
This patient is a good candidate for the Top Gear trial that actually randomizes between pre-op chemo followed by surgery followed by further chemo, or pre-op chemo radiation followed by surgery followed by post-op chemo. So I would suggest this patient to participate in the Top Gear trial.
And you would still do that even with the R0 resection rate of 60% after getting preoperative ECX without radiation?
Well, the trial is currently ongoing, and according to the first interim results, the R0 resection rate is higher in the Top Gear trial.
So David, comments about ECX versus CF preoperative treatment?
Yeah. Is this microphone on? Okay. I think my comments would be, that's better. Of course, you didn't include the option of a perioperative ECX, 3 cycles before and 3 after. I mean, the problem with the study I've just presented, of course, is that we changed a number of variables. But my sense here is that it's important that we integrate radiation in patients where we think there will be a positive margin. And our challenge is trying to work out how to optimize the chemotherapy into that whole regime. And I mean, looking at those data, and the problem we also had in that study, incidentally, is that if we'd compare 4 cycles with CF with 2 cycles of CF, would we have got the same result? And the trouble is we don't know. We don't know whether the higher path CR rate was due to 3 drugs or 4 cycles, but what we were trying to do was just maximize the likelihood of improving outcomes. But I think that people could use ECX if they felt they wanted a higher tumor regression grade, if they had a younger group of patients. Because there is evidence and a signal that there's a higher response rate. So people can look at those data.
Do you think the higher response rate was just because patients had surgery a little later and maybe just giving the chemotherapy more time to impact?
Well, I think that's true, yeah. And that's the problem with the study design, and I take full responsibility for that. That we change 2 variables at the same time, and the best studies are always really simple. But what we were trying to do here was maximize the chances of improving outcome with a triplet over a doublet and longer treatment. So I just can't answer that question.
Florian, the practice in Germany, is it going to be impacted by OE05?
I wouldn't say at that stage. I mean, in Germany we do not use so much epirubicin, at least not when it comes to esophageal and EG junction cancer. And my only comment is I'm a little bit concerned about the 25% who voted for surgery first in a patient with a T3N plus stage tumor. This is surprising to me. Obviously not everybody is convinced by the large amount of preoperative studies that have been positive, and I think we have to work on that.
Maybe Dr. Allen can comment about upfront surgery. Should it be done, or should we give all patients neoadjuvant treatment?
I think the studies support neoadjuvant protocols, whichever one you decide to take on. The experience we have with this disease is that the vast majority of T3N0, N1, we've got plenty of evidence that those patients fare much better by having perioperative treatments. And I think you will probably find you've got a higher R1 resection rate if you went for surgery first. The only point I would make is there is potentially a need, and it may be a pathological question. The definition of a resection margin positivity is variable. In the UK and in a lot of European centres, it's less than 1 millimetre. Some actually right up to the margin. So I think we'll be fairly careful. We are comparing like with like on that.
You know, no one picked induction chemotherapy followed by chemoradiation. There actually is a small randomized trial that showed that adding induction chemotherapy doesn't add benefit. So one last question to the panel before we move on. How much is enough chemotherapy? It seems like we don't get any more benefit after 2 cycles of treatment. So how much is enough?
I mean, how much is too little? I mean, that's one of the other issues that with the Dutch study, there's actually very little chemo in there. And it's why there is systemic failure. We still know these people are dying of systemic disease. But it may be that the tools that we have available to us are simply not good enough.
Florian.
My comment would be that regarding the duration of chemotherapy, we have 3 positive studies, starting from OE2 to MAGIC to the French study. So something between 6 and 9 weeks should be optimal.
Yeah, it's just very interesting. I think that our treatment is just not effective, and we need to develop better systemic agents that probably suppress rather than eradicate metastatic disease. Okay, let's move on. Okay, so let's assume, what if the HER2 testing is 3+?
We don't test.
So does this change your choice in therapy for a T3N1G junction cancer? So trastuzumab plus paclitaxel carboplatin radiation followed by surgery and a year of trastuzumab. Preoperative FLOT chemotherapy plus trastuzumab, then surgery followed by FLOT trastuzumab and 1 year of trastuzumab. Perioperative FLOT with trastuzumab and pertuzumab, preoperative FLOT alone, or preoperative paclitaxel carboplatin radiation and surgery without other treatments. Okay, so the majority would go with one standard of care, paclitaxel carboplatin radiation. And the next biggest group would actually add trastuzumab to the mix, even though we don't really have data yet. And then a small percentage for using FLOT with trastuzumab, and no takers yet for pertuzumab. Comments from the panel?
May I ask you something? Why did you test for HER2 in this situation?
Well, I tested for HER2 because I wanted to see what the audience would come up with.
Well,
we have an ongoing trial in the U.S. looking at trastuzumab, so we are testing these patients.
That's another story, but my comment would be I'm in the happy situation where the pathologist still does what we ask him to do. He's not testing that automatically, and we just test for that if we have a trial open.
Yeah, currently outside of a study, it's not typical to test for HER2, but this is a hypothetical case. So.
Yeah, I mean, I'm very encouraged by the German data with chemo plus trastuzumab. I think that there's more than a 20% path CR rate. And if you ask me what's the highest priority in this disease, it's to complete the trial that shows that trastuzumab improves outcome. I mean, we don't have those data, and we do need them. I mean, I think like most people in this room, we believe that it will probably be positive, but we've got to do that piece of research. It's critical.
I think the RTOG study is accruing quite well, and I think it's going to complete accrual, if not this year, next year. No readouts yet we don't have any pathologic CR data yet. It's powered for overall survival. It does seem that adding trastuzumab to chemoradiation does not increase toxicity. Maybe Florian, you can comment on ongoing trials of HER2-targeted therapy with chemotherapy.
Yeah, we are just starting within the ERTC network a randomized trial, which is called the Innovation Trial, and it randomizes patients to receive chemotherapy alone or chemotherapy plus trastuzumab, and in the third arm, chemotherapy plus trastuzumab plus pertuzumab. We are currently starting to open the centers in Europe and also in Korea.
Okay. So if there are no other comments, let's move on. So the patient is HER2 negative, and he receives preoperative paclitaxel, carboplatin radiation, and undergoes Ivor-Lewis esophagectomy. His pathology reveals a 50% treatment effect, but there's residual T3 disease, and 2 of 20 nodes are positive for metastatic disease. So what now? Observation, post-operative ECX, post-operative Folfox, post-operative FLOT, entrance onto a clinical trial comparing observation versus 1 year of regorafenib. Observation, 80%. I think that would be the standard of care. The next most popular choice, but not by a distant second, is post-operative Folfox, and a few picked post-operative ECX. Nobody's interested in a clinical trial of observation versus regorafenib. That's actually the CLGB trial in the United States. Given that the standard of care would be no further treatment, we're looking at that versus a VEGF targeted agent. So comments from the panel. Dr. Allam, this is the most asked question from my surgeons. They said, you have to give this patient more chemotherapy. Do you accept no more treatment from your medical oncologist? What do you expect?
We have, as you know, the STO3 trial on running with the perioperative chemotherapy, so this patient would already been entered into that study, which, as you know, is closed, and it follows on from our previous experience with MAGIC of using post-operative ECX, so we would be in that small 5%. The only issue I would raise is the extent of that lymphadenectomy. Only 20 nodes begs a question about the extent of the lymphadenectomy. Our practice is a 2-field node dissection, both intra-abdominal and in the chest, and 20 nodes. I'd be wondering if the extent of lymphadenectomy is sufficient, so you could have a stage migration issue.
Okay. Practice in Germany, Florian, for such a case?
Well, actually, the recommendation from our guidelines is to give pre-op and post-op. But I think at the current stage, it's a question that nobody can answer what the value of any addition of more treatment in the post-operative phase really is. So I do not have an answer to that. There are standards established in centers, but I think nobody knows what the best standard is.
David, what's done in Royal Marsden?
I mean, I think this is really at the heart of our problems at the moment, because here we have a regimen that has produced a survival of benefit equivalent to chemo, say, chemo-rad, but the driver was mainly squamous. I know that the hazard ratio was also positive for adenocarcinoma, but the big driver was squamous, and we intrinsically think that there must be a case for better and more systemic chemo. But there is no evidence that doing anything after this particular regimen makes any difference because the trial has not been done. That's the problem.
And if we actually look at studies in gastric cancer where they've tried to sequence different regimens and add additional therapy, there doesn't seem to be a signal there either. So maybe if I had put an immunotherapy drug instead of regorafenib, we would have gotten more takers on the trial question. Okay, let's move on. The patient is observed. 18 months after surgery, he presents with right upper quadrant pain, and a CAT scan now shows bilobar hepatic metastases, and a biopsy is positive for metastatic adenocarcinoma. He has a good performance status, and liver biopsy results are pending. So your next step is genomic sequencing, looking for a targetable mutation, treatment with FOLFOX or CAPOX, treatment with EOX, treatment with FLOT, treatment with FOLFIRI. Okay, so about half picked FOLFOX or CAPOX, followed by EOX. I guess there's some French attendees in the audience who picked FOLFIRI. And genomic sequencing looking for a targetable mutation. So preferences for metastatic disease treatment from our panel. Dr. Cunningham.
Thanks, Dave. Thank you. I think you're killing me up here, David. I think that obviously EOX is one of the standard treatments. We can argue about whether epirubicin is essential or not. I mean, we have median survival rates of around 11.2 months. Obviously, the ECX versus FOLFIRI trial reporting the JCO was not ECX. It was modified ECX, so the results have to be interpreted with caution. People, especially North Americans, but not solely North Americans, have gone to using FOLFOX, and it's a good regimen in this disease, but without really much evidence. I think these are all very reasonable approaches. I mean, we would have done HER2 on this patient as a key thing when they have metastatic disease to establish whether they would benefit from trastuzumab. Gene sequencing, I mean, this is just research at the moment.
Okay, Florian?
Well, obviously, I would go for HER2 testing first and would base my treatment choice on that. And for the rest, I mean, we tend to give triplets in Germany, including Taxotere, for those patients who are symptomatic, who have a high tumor load. So I would also include that into my decision tree. If he's symptomatic, if the tumor load is high, I would go for a triplet. For all other cases, I would go for a doublet, FOLFOX or Platin-5FU, or even FOLFIRI.
It doesn't look like Marcus voted, so no flat votes.
You mean Salah? Yeah.
So now the liver biopsy comes back 3+, good performance status and normal LFTs. So should we give the patient capecitabine, cisplatin, trastuzumab, capecitabine, cisplatin, trastuzumab, and pertuzumab, FOLFOX, trastuzumab, FOLFOX, lapatinib, FOLFIRI, trastuzumab, or other? Okay, so 60% chose standard of care capecitabine, cisplatin, trastuzumab, and then the second choice, FOLFOX, trastuzumab, and pertuzumab. I guess we await the results of ongoing randomized trials. And fortunately, nobody picked lapatinib, which failed first-line evaluation. Okay, let me move on. So the patient gets FOLFOX and trastuzumab, pain gets better, he has some GI toxicities and requires dose reductions in 5-FU. CAT scans out to 8 cycles show a response, and oxaliplatin is stopped at a cumulative dose of 750 for neuropathy. So he continues on 5-FU trastuzumab alone, and he continues to show maintenance of response, and he's now 8 months into treatment, and his neuropathy is grade 1. Your choice of treatment at this time is just to continue 5-FU trastuzumab, continue trastuzumab alone, stop therapy and observe, reintroduce oxaliplatin to the treatment or other. Okay, so actually a split between continuing 5-FU trastuzumab alone or just continue trastuzumab. Very few favored stopping treatment altogether. Comments from the panel about, do any of you use trastuzumab maintenance therapy by itself?
Yeah, this is the trial design. Chemo, then maintenance trastuzumab. So that'd be generally what we would do. And we tend to use, we're actually using cisplatin more than OX now because of peripheral neuropathy and the likelihood that, I know you'll come on to this, we're going to use a taxane second line.
Florian?
Yeah, we also go for trastuzumab maintenance. It's according to the TOGA study, so there is a rationale to do that. Also, of course, there are no randomized data if it would be possible to stop all treatment or do anything else. But interestingly, we are currently focusing on that thing in Germany. There are some long-term survivors during that treatment. Our impression is that really some of these tumors have a high dependence on HER2 as a driver. So I think currently maintenance of trastuzumab is justified.
Yeah, it's unfortunate that TOGA study, they never publish any follow-up on what happened to the maintenance patients. We have really no data about what happened to those patients. Okay. 5-FU trastuzumab is continued, response is maintained out to 15 months. He's now hoarse, losing weight, and a CAT scan shows progression at all sites of disease. Now he gets the genomic profiling, and it shows HER2 amplification, FLT3 mutation, which is an activating mutation, downstream signaling through AKT, RAS, and mTOR. This is actually a real patient. Amplification of CRKL, which may impart sensitivity to SRC, BCR-ABL kinase inhibition. He has the ubiquitous P53 mutation, loss of SMAD4, and RUNX X1. So, your next choice of therapy, reintroduce the platinum to 5-FU trastuzumab, paclitaxel plus ramucirumab, paclitaxel plus trastuzumab, FOLFIRI with or without ramucirumab, TDM1, regorafenib or sorafenib, which targets FLT3 or other. Okay, so a smattering of choices. Some would reintroduce the platinum. The second most common would be paclitaxel ramucirumab based on the recent data. And then the third most common would be to do paclitaxel plus trastuzumab. And then actually 11% picked regorafenib or sorafenib, even at this point, without second-line treatment. Comments from the panel?
I mean, I would say that reintroducing the same regimen would be quite reasonable because they responded before. And in this disease, the one thing you do want to do is keep your options open, maximize the benefit from the regimen that you know has worked, and then maybe hold paclitaxel in reserve. So it's an unusual scenario.
Any takers for continuing trastuzumab into the second-line treatment versus ramucirumab?
No data on that. I mean, we have some data from breast cancer that it makes sense to continue trastuzumab beyond progression. We do not have these data yet in gastric cancer. I think the heterogeneity of responses tells us that there is a need for clinical studies for HER2-positive patients who progress on trastuzumab.
And we certainly have some interesting data for regorafenib in late-line treatment, but probably not a second-line.
Not
it would be a later-line treatment. Okay, I think this is the last point before we move to the next case. So the patient gets paclitaxel and ramucirumab, progresses on treatment, and has good performance status. So third-line treatment, FOLFIRI, irinotecan monotherapy, TDM1, referral for phase 1 trial, best supportive care, or other. Okay, so we have a split between FOLFIRI and referral for phase 1 trial. I think at this point would be quite reasonable. Irinotecan, I think, would be the standard fallback here, but interesting to survey practice. Any last comments before we do? We have time for the second case, so any issues on this case? Last points. Okay, great. So I'm going to turn over the podium to Karen Haustermans, who will present the next case.
Thank you, David. So the case I prepared is a male of 53 years old. Actually, it's also a real case. He's an accountant. In his previous history, we noticed COPD, leukoplakia in the floor of the mouth. In 2006, he had a rib fracture, the 10th rib on the right side dorsally. He uses quite a lot of alcohol, 10 units per day, and for smoking, he has 40 pack years. And he presents with dysphagia, with a duration of 3 months, and a weight loss of 12 kilograms. He currently weighs nearly 50 kilograms, so he lost more than 10% of his weight. His length is 1.68 m. The further clinical examination shows no abnormalities. The lab results show a normal kidney function and a slightly higher CA value. So in this patient, what is your next step? Will you go for a gastroscopy with biopsies? Would you go for a CT chest abdomen, an FDG PET-CT, a bronchoscopy with biopsies, an endoscopic ultrasound, or an esophagography? Okay. Yeah, here's the voting. And most of you chose the option we also performed, a gastroscopy with biopsies. I don't know whether any of the panelists would like to comment on the different options.
I mean, you need a diagnosis before you move forward. So.
And the most straightforward thing to do is a gastroscopy. So that was performed, and it showed a stenosing tumor just below the cricopharyngeal muscle, and the biopsies showed a well-differentiated squamous cell carcinoma. A CT scan of the chest and the abdomen was then performed, and that showed a tumor in the proximal esophagus in close contact with the trachea, no adenopathies on the CT, and no metastasis. So the next question is then, who of you would do an FDG PET-CT in this patient? The majority of you would do an FDG PET-CT. Florian, can you comment on this?
Probably those who voted for yes, they want to exclude distant metastases because that is the strength of PET-CT in this situation, that you exclude metastatic disease. Actually, the availability of PET is different across the countries where we are from. We in Germany, for instance, do not have a good availability of FDG PET outside of centers, and so many of us in this situation do not include a PET-CT in our algorithm.
David?
Yes, I mean, I think this is a localized esophageal cancer. The staging would be, we would do a PET scan, certainly, because you'll find disease in bone, in liver, in nodes that you might not pick up on CT.
David, number 2, you agree?
Yes, I think PET scan is mandatory. It's a high enough positivity rate, it may guide the radiation fields, should be done.
A PET scan was indeed performed, and on the PET scan several lymph nodes were detected, and as well as the primary tumor. So the next step then was that we performed a bronchoscopy with ultrasound-guided biopsies in lymph node station 4 and 11 on the right, which were pathological on the FDG PET-CT. On the ultrasound, there was no clear tumor infiltration, and the pathology was negative. As this patient lost quite some weight, before starting treatment, how would you feed this patient? Would you go for intravenous alimentation? Would you go for a jejunostomy, a gastrostomy, a nasogastric feeding tube, or other options? So the majority chose for a gastrostomy. Maybe the surgeon can comment on the different options?
I think it's tolerability. Our preference is to do a jejunostomy because we find the patients tolerate it better. But equally, with this situation, a gastrostomy is entirely reasonable. It's just our nutritionists seem to prefer supporting such patients with a jejunostomy. The rates of complications between the two techniques are probably more or less equivalent. Certainly not intravenous, and patients do not tolerate an NG nasogastric tube.
I agree with your comments. I don't know what the other members think of these options.
We don't rush and put feeding tubes in patients. We often start them on chemotherapy, and you can get dysphagia relief in about 70% of patients if you give them some chemotherapy before you start the radiation. So I don't rush and put feeding tubes in these people.
Okay. Any other comments?
Yeah, I think that I'd agree with David. In general, we don't feed these patients, but I think what you've illustrated here is that this patient was really very thin. And you probably is a good example of where we do need to feed as well as give treatment.
So how would you treat this patient then? So it is a squamous cell carcinoma in the proximal part of the esophagus with positive lymph nodes around the tumor. Would you go for pre-op chemo radiation, definitive chemo radiation, primary surgery, or other? The majority of you choose for definitive chemo radiation. Again, I would like to ask the advice of our surgeon.
Our practice in the UK is certainly for more definitive chemoradiation. There are differences. This is really quite a proximal tumour, what you presented so far, and therefore we would err on definitive chemoradiation. The need for surgery in some of these is if you've still got residual disease having completed that regimen.
Can you explain what surgery would mean in this patient?
This is, if you're putting it just below cricopharyngeus, which puts it actually out of our category. It puts it more into the head and neck surgery category. So I'm going to slightly dodge that because you'd actually have to you're going to have to take pharynx and esophagus. Depends on proximity to the larynx. I mean, the CT, however, does show a little bit lower than what the endoscopic findings are. So it is obviously quite close to the back of the trachea. So you may have room for esophagectomy and a gastric pull-up.
Okay. Can the medical oncologists comment on the options? Maybe Andres can give some comments?
I think this would be my preferred option because surgery is related with a lot of morbidities. So I think definitive chemoradiation is effective. About 25% of those patients may have maybe long-term survivors. So I think it's the best option for me.
Okay. So let's move on then. So this patient went to the MDT discussion, T3N2M0 squamous cell carcinoma of the proximal esophagus, well differentiated, and we chose for definitive chemoradiation 45 gray to the elective regions and 55 gray in 25 fractions, so a simultaneously integrated boost on the macroscopic tumor with weekly carbo and paclitaxel. And here you see the IMRT plan where you can nicely see that the higher doses were delivered to the macroscopic tumor and 45 gray to the elective nodes. We did not risk to omit the pathological lymph nodes on PET-CT, although the pathology was negative. Now, what if the tumor was located at 25 centimeters? Very similar case. Would that change your choice of treatment? So, mid-thoracic squamous cell carcinoma. Would you then go for pre-op chemo radiation, the cross schedule, or pre-op chemo radiation to 45 gray with cis-5FU, or definitive chemo radiation, or primary surgery, or other. So this is interesting. Now we see a switch from definitive chemoradiation to pre-op chemoradiation, and there it's around 50-50 between the cross schedule and the more classical 45 gray with cis-5FU. Maybe I first ask the advice of the surgeon. Would you go for primary surgery or would you choose for a pre-op treatment, and what would be your preferred option then?
Certainly not primary surgery. It is interesting because in the UK we are still in the main doing definitive chemoradiation for these patients, partly because of the nature of the patients that we see, that they are often significantly affected with other comorbidities. And the combination of chemoradiation and surgery in our hands has not been very good. I recognise that both in North America and in Europe, either of the first two, either of 2 and 3 are the preferred options. Our experience is, however, beginning to gain, and in the light of what David said with regard to the adenocarcinomas, I think we're going to probably change some of the approaches that we are adopting in the UK. The issue with regard to preoperative chemoradiation, which we have tended to reserve for those with locally advanced tumours, where a patient is younger and gets a good response, is the timing of when the surgery is undertaken, because of the issues of the ability to resect the tumour with aiming at an R0 resection. And we're tending to look to longer delay than conventionally we do with preoperative chemotherapy. So we're going out beyond the 6 weeks, almost to 12 weeks in certain circumstances, without any apparent adverse effect.
And do you consider then salvage surgery? Because the 2 randomized trials that looked at the role of surgery in this disease showed that local regional control is superior if you choose for pre-op followed by surgery compared to definitive chemoradiation, although overall survival is the same. So if these patients do not metastasize but have a local regional recurrence, would you then go for salvage surgery or leave it like it is?
I think there's 2 groups. There's the patients who have residual disease after chemoradiotherapy, and it depends on their comorbidity. And there's those patients who then relapse some time after they've completed treatment. Although no significant trials have been done, it does appear that those who use salvage, who've had a reasonable disease-free interval, actually fare better than those who've got residual disease. Technically, it can be challenging because of the fibrotic reaction, particularly close to the airway.
David, would you like to add something?
Yeah, maybe just a final comment to close this out. I'm surprised at the number of people that pick platinum. The number of people that pick platinum 5FU still is toxic old regimen that I think carbotaxol should replace. And also the data from France that 5FU oxaliplatin can be substituted for 5FU platinum. So I'm surprised about the large number of the members of the audience that would still give patients platinum 5FU. I think it's a regimen that probably should be abandoned.
Okay, thank you for your final comment. Also, thank you for the audience for the interaction and the voting. I think it was a good tumor board. Thank you.